If you're a healthcare professional who treats veins, such as spider veins, varicose veins, venous eczema, or venous ulceration, you're in the right place. Today I'm super excited to be joined by Ronald Bush from Florida. Ron is board certified in vascular surgery and has published extensively on many areas of venous disease. He also has board certifications in thoracic and general surgery, having completed residencies at Walter Reed Army Medical Center and Indiana University. He speaks at major vein conferences throughout the world, and I've been influenced in my practice by his presentations and publications. We're going to talk about his innovative use of foam sclerotherapy around leg ulcers, a technique he calls terminal interruption of the reflux source, or TERS for short. And be sure to stay to the end when we learn about a new approach to venous disease called Dermatophlebology, and we'll be learning about some really great resources that Ron and Peggy Bush have put together. I've heard you speak, and my practice has been significantly influenced by what you've published and what you've presented. In particular, your tumescence-assisted treatment of spider veins, where you flood the area with tumescence and you extract the reticular vein through a little punch biopsy perforation in the skin. Recently, I've been particularly interested in the public health problem of leg ulcers, and it took me back to your innovative approach and your publication in 2010, where you described the use of foam sclerotherapy around the venous ulcer bed. Right. And that struck me as a very unusual approach. And I wanted to ask you, Ron, what led you to do that and why you thought that was a reasonable thing to do?
Well, I had a patient, I think it was around 2006, 5 or 6, had a venous ulcer. She had it for around 6 months. Had been to a wound clinic and really had no resolution. At that time, of course, that was when SEPS was popular and treating perforators. So I injected the perforator with Citrodeckel foam and saw her back in follow-up. At 6 weeks, the ulcer is completely healed. And this is a very large ulcer. It's probably about 8 centimeters. And we did an ultrasound. The perforator was still open. But underneath the ulcer bed, or the ulcer itself, there were no refluxing vessels. So that was kind of the clue that maybe we're looking at the wrong thing here. Maybe we could treat this as a local phenomenon and see if we could aid and increase the healing. So from then on, any ulcer I saw, when I first saw them, I injected them with foam sclerotherapy. Using an ultrasound, tried to pick the vessels that was closest to the ulcer bed. It was amazing. I mean, the only 2 or 3 that we had trouble healing were ones that we under further examination found out had obstruction of the iliac vein. And then after the obstruction was relieved, they had really good results. So for superficial reflux, it was very good, isolated, but also works for insufficiency of the deeper venous system. And there's a perfect storm that has to occur with venous ulceration to occur. 1 to 3% of the population of venous ulcers, yet a significant portion, probably over 20%, has really severe venous disease, and 40 to 50% have venous reflux at one time or another. So we think what happens, based on our histological studies that we've done in our lab, is that, first of all, you have subpapillary reflux. The subpapillary plexus in the skin, there's a subpapillary plexus, a middermal plexus, and then a subdermal plexus. Now, they're all fed by the dermal perforator. It's interesting to know that not a lot of work's been done on the skin circulation in venous disease. And that's how we kind of got our interest was kind of intensified when we started looking at some of these specimens that we were doing. I work in the largest dermatology practice in the United States. So I think it's the second largest. And we have a dermatopathology lab. And I work in close association with the dermopathologist there, Dr. Russo, and Dr. Schiff, who he's also a dermopathologist. We've made a lot of interesting discoveries, but in the case of ulcers, it's all related to a polygonal area of drainage. Amanishi in about 2010 talked about polygonal drainage areas for the venous circulation. So what happens is, if you know, spider veins are always in like a triangular pattern for the most part. Well, that represents an area of polygonal drainage fed by one dermal perforator, maybe two. In an ulcer, okay, you have the venous drainage, the area that usually ulcerates is in, of course, the medial lower leg. It can be on the anterior foot, or it can be laterally from the SSV venous circulation. So what happens is you have incompetency in the subpapillary plexus, and that's where the ulceration occurs, subpapillary plexus. You never see an ulcer, very rarely ever, much deeper than about 1,000 microns. It can be in diameter much larger, but not in depth. So what you see when you look at the granulation tissue is actually over the reticular dermis itself. So what happens is you have incompetency in the subpapillary plexus, and you can see this in larger vessels. In some of the biopsies we do for other studies, we can see the normal size. We can see what it looks like when you have stasis changes, what it looks like when you have advanced stasis changes, what it looks like when you have eczema. They're all different kind of patterns. Everything looks different as far as the class of venous disease. There's no one, everything doesn't look the same. So when you have subpapillary plexus reflux, that's fed by dermal perforator. That dermal perforator is connected to an underlying reticular vein that must be dilated and refluxing for the ulcer to occur, which also must connect to a perforator as a drainage pattern. So when you have decreased drainage through this system, then you get really high pressures. Most people with a venous insufficiency, they'll have high pressures, but they'll be able to have venous drainage at some point. So they don't get this huge amount of pressure that's built up. And once this occurs, then anything can set off the ulceration. You can have a small puncture wound, you can scrape it, whatever. But that's why I think most ulcers occur in just really in one location. They have to be associated usually with this most of the time, what we used to call mid-coccus perforator. And so that's the setup. That's why they're all in that area. And even the ones on the foot that I've treated have associated perforator pathology, like the plantar reflux and plantar perforator. So I think that for an ulcer to occur, there's got to be three different things going on. And that's why people used to treat perforators for venous ulcers. Although when you treat a perforator, as you know, foam is deactivated very rapidly. So you're not going to get foam penetration to the ulcer bed by just injecting a perforator. You have to have enough foam get into the ulcer bed to occlude the small vessels. By occluding the vessels, what happens is then you have a normal venous pressure at the margin of the wound, and then you can start healing. So I think we're kind of on the right track treating perforators, but wasn't the right way to do it. The right way was to treat the ulcer bed, and then many times the perforator will actually become more competent because now you don't have an overload.
Right. Okay. So you found this, you came across this technique really by chance,
Right.
by observing that in attempting to inject a perforator,
Right.
which you thought was the underlying problem, the foam spread into the ulcer bed.
Right.
The perforator remained open.
Yes.
The veins underneath the ulcer bed became occluded, and you observed that despite the perforator being open and despite the continued superficial venous reflux in the saphenous system, the ulcer healed.
Right.
So it was acute, it was very observant and thoughtful, thinking around that observation that led you to believe that it was the ulcer bed that was the thing that you should treat. So you published it.
Yeah, the easiest thing to treat. Yeah.
Yeah. So you published a series of a few in 2010,
Right.
and then you followed up with a larger series. And subsequent to that, Ron, there have been very few publications. I think there's been probably 4 or 5 publications that I can find Are you
Right.
aware of any more that
Well, recently there's been more publications. There's been 3 or 4 in the last year. Now, I think they point out, some of the publications point out the rapid healing you get with foam sclerotherapy. And I think one of the comparisons they did, one paper compared foam sclerotherapy with compression alone. In foam
yes,
sclerotherapy, there was a rapid healing, twice as much healing in the of the ulcer compared to compression alone. Now, the problem was, after they did that, everybody got endothermal ablation. So, I mean, it's a good study to start, but it's not a good study to finish. The study from Ireland, which actually identified the people with venous ulcers that were treated with foam sclerotherapy, and I can get the paper right here if I can find it. There's a okay. Now let's talk about this one first. Okay, so axial ablation versus terminal reflux. Okay, of the source, a randomized controlled trial. Now this was done. Yeah, this was done and out of Ireland. And what they did was they did the foam sclerotherapy. Okay, but they didn't do follow-ups. Okay, their basis of the results was the time to healing. Okay, now they didn't do follow-ups with ultrasounds during the time to the healing. They just had observers say the ulcer's healed at X amount of days. They didn't really follow up and say, is the ulcer bed closed? Now, my experience, and I think there's another report too that shows that 20% of these patients will need a second injection within 2 weeks. It's not a one-time deal for many people. It all depends on the amount of reflux and size of the vessels. The technique relies on follow-up in 2 to 3 weeks and re-injecting foam at the ulcer bed has not, if you still have reflux under the ulcer. Now, when you do this foam sclerotherapy, you can see two different things. You can see foam in the ulcer bed, under the ulcer, in the subdermal area where the vessels are. You may also see foam in the true ulcer itself, the ulcer bed. You see this with eczema. When you inject a patient with eczema, you won't see refluxing vessels underneath the subdermal area, but you'll see foam actually in the dermis. Okay? So if you see foam in the dermis and in the vessels under the bed when you're treating an ulcer, that's almost 100% sure one treatment, because now you've penetrated from the subdermal area up into the small vessels in the subpapillary plexus. You see the haziness when you do the injection. I wish I had a slide to show you. The foam above the skin line, okay? Then you can see you've had a good result. You know that's going to heal up very well. When you do an ultrasound, you see the line about 2 millimeters below, you'll see the line of the fascial line of the dermis. Okay, if you have a really advanced ultrasound, it's much easier to see. The one I use, it's 7.5 megahertz. So you don't see the skin as well as you should, the actual skin itself. But there are ultrasounds out there that show that. So foam penetration is an excellent sign. When you're above the dermal line, you have foam like you do when you inject a patient with eczema. You'll see a really nice foam layer below, and you'll see it in the vessels below the dermis. You have a really good chance of that being well. Now, these papers didn't really follow up with ultrasound, most of them. There's another paper that wrote about using a vein light, okay? We've done that for a long time. In fact, they didn't even quote our work that we'd done in their paper, which was obviously they hadn't done a search of the literature because we described percutaneous foam sclerotherapy back in 2013. Now, again, observation, why that occurred is very interesting. After the earthquake in Haiti, my wife and I were probably among the first doctors in the southern part of Haiti in the region of Choc Mount. And so we were doing a clinic and the hospital was destroyed. Doing a clinic, and we had, there were people lined up for miles to be seen, and didn't have an x-ray at that time, had nothing. I didn't have an ultrasound. Set, fractures the best way you know how. Or you didn't know if it was good or not or what. But we had a patient come in, and this patient came in, he had an elastic bandage on his leg, and he took it off, and he had a perfectly circumscribed area of ulceration in the lateral ankle from an SSV reflex. I could actually feel the vein. So we thought, how? So we got back home, we thought, how could you treat these ulcers without an ultrasound? And so that's how we came up with the theory of using percutaneous. Find a vessel you can see, inject it towards the ulcer. You can do it through a spider vein, although there's a little bit increased chance for skin necrosis when you do a spider vein, or you can do a reticular vein, or you can use a vein light. So the whole beauty of tears, I think that people miss, is that you can treat ulcers worldwide. You don't need an ultrasound. You need 2 syringes, a stopcock, and a sclerosant. And you can treat about 98% of the ulcers you see with that alone. Just looking at the patient's leg, finding a vessel close by, or palpating a perforator, that's close to it. Anything you can to get foam into that area of the ulceration. And that's why tears is important. I think you can do tears without doing anything else. I mean, in my experience, I've treated patients like that for age or for economic reasons couldn't do the intravenous ablation. And they've done very well. Now, they may have a reoccurrence, but it's never been in that area, in the ulcer bed. It may be around there someplace. But once that ulcer bed is sealed, that's it. You don't get a reoccurrence in the ulcer bed. So I think, the beauty of tears and the concept of tears is that this is a technique that can be done worldwide. You don't need all kinds of fancy equipment. You need a sclerosant, 2 syringes, and a stopcock, and a scalp needle. That's it, or a butterfly. So I think if doctors would realize that and get that out there, that we could help a lot of people that actually suffer needlessly with these things for a long period of time.
Okay. Well, I'm going to stop you there, Ron, because you've kindly sent me a video where you actually demonstrate the technique.
Right.
I'm going to show that now, and then I'm going to come back to you, and I've got some questions for you.
Okay. Venous ulcers occur in 1 to 2% of the population. They may be associated with superficial reflux, deep reflux, or venous obstruction. While it's known that ablation speeds healing of the ulcer compared to compression, we might ask the question, is there another adjunctive therapy that is simpler and can be done more effectively? The answer to this is a tears technique, which I described in 2010. It's being used in many parts of the world, and there's more and more written about it in the literature every year. Now, the tears technique is simply foam sclerotherapy to the ulcer bed. It can be done percutaneously or by ultrasound. By clotting the refluxing vessels in the ulcer bed, you decrease the venous pressure, decrease the inflammation, and it's like an internal compression dressing. So the tears technique is very effective. In fact, I use it when I first see the patient. It promotes healing. The ulcers heal compared to compression alone at least twice as fast. There's also a great reduction in pain after doing this technique. When you have an internal compression dressing, you only need a very light external compression. We do wound care, either VASH or irrigation with a saline. We use an adaptic dressing. There's a lot of drainage. We may use one of the other products, but however, simply we use a small non-inclusive pad, non-sticking pad, 2x2s over this, and then an ACE wrap or a 20 millimeter sock. And this really is all you really need when you do the internal compression. Now this is a venous ulcer, 2 weeks duration, and the patient has wide open saphenous insufficiency. I'm going to show you the ultrasound here in a minute. We're going to do the percutaneous foam technique. We're going to inject right there. You could inject here. You can inject any place you find a vein, even through these small veins. In her case, going to use 1.5 Siltradecal foam. And so I'll show the ultrasound here in a second. Now, these are all the incompetent vessels underneath the ulcer bed right here. And what we're going to do is inject foam percutaneously to clot these off. And you can see there's a lot of them right there. So the tibial vessels are down lower. All right. This is using saline through a 3cc syringe and a 30 gauge needle. It makes like a little angiojet, helps to bleed. In fact, pretty painlessly doing this. Okay. Now we've done percutaneous foam injection through a small little varice that in close proximity to the ulcer. Now what we're going to do now, see how much we fill it up. If it needs a little bit more filling, we'll inject right here. Okay. Now you can see the foam is in the ulcer bed right here. It's good penetration. So it's all we have to do, put a Talfa pad and a ACE wrap, and that's it. See you in 2 weeks. Now this is the ulcer. This is a previous resection for a squamous cell carcinoma that never healed, and they had bilateral GSV insufficiency. We've closed off the GSV above, but we're going to show you the ultrasound. There's still incompetent vessels that go right into the ulcer. So we'll try out the lights here and I'll show you the ultrasound. Now this is right into the ulcer bed where this reflux is. And so we're going to put foam here today. He's on anticoagulation. We're going to try 1%, see how it works. But you can see it goes right into the ulcer, right over the ulcer bed now. And there is reflux there. Okay. Now you can see all the foam right here into the ulcer. This is going right into the ulcer bed right here. This is the GSV where we injected the Lorban. Okay. And I kept my finger compressed above where we injected, so there's no foam going this way. It's all going distally. It also has a small perforator in there, but then you can't really see it now because it's been foamed shut. Okay. Now this image demonstrates percutaneous foam sclerotherapy for a lateral ulcer secondary to SSV insufficiency. Now, in conclusion, tears may be used for ulcers of all different etiologies, such as deep reflux, superficial reflux, and obstruction. If obstruction proximally is the etiology, this should be also corrected early as possible to speed healing and prevent ulcers in other locations. It is possible to use this technique in all ulcers secondary to superficial reflux and deep reflux as a sole treatment in clinically compromised patients. At some point, it is also possible to foam the distal GSV or a Cock's perforator if these are incompetent. However, by doing the tears technique, this ulcer will heal with nothing else being done. You only do adjunctive procedures to prevent future ulcerations that occur not in the location of the current ulcer, but another location.
So Ron, you've kindly shown the technique being performed. You say it can be done without ultrasound, with a vein light. It can be done by palpation and visual inspection. And you've said that it has the potential to treat 98% of venous leg ulcers. The question is, Ron, for you, perhaps, you've probably pondered this more than most people, why aren't people doing it? Why are there so many people with venous leg ulcers languishing without any treatment? Do you have any thoughts on that?
Yeah, I do, because I think medicine is driven by monetary concerns.
Yeah.
Simple as that.
Okay. Yeah.
That's why they languish in the wound clinics, because they get so much money for debridement. That's why you don't get paid for doing this for the most part. I mean, you can if you have distal saphenous insufficiency, you can treat that and get reimbursed. But even with that, I mean, sometimes that's not enough because you don't get foam in the ulcer bed. So you have to combine that with doing the foam sclerotherapy itself around the ulcer, around the incompetent vessels. But I think it's a monetary concern. I think there's thousands of vein clinics in the United States. There's one on every corner. My God, it's just unbelievable. Most people just do intravenous ablations, and they don't really understand the pathophysiology of venous disease. And it's bad. I see many patients in my clinic that had needless procedures or had the wrong procedure at some of these, jack-in-the-box vein clinics. It's not a good thing.
Okay, well, there is increasing interest in TERS now, and my hope is that we will educate both the public and the healthcare professionals about TERS, and hopefully we can persuade them to treat more venous leg ulcers effectively using your technique, Ron.
Right. It's such a simple technique. It's so simple for the patient. And so why don't we do what's right for the patient? And maybe even if the insurance companies that people are worried about it, get a category for treating venous ulcers with, the tears technique. I mean, there's ultrasound guided sclerotherapy, but I mean, even the insurance companies don't recognize, what you should do for that gets the best results. I mean, you have people sitting on these review committees and peer reviews, and they don't know. I mean, a couple of peer review people I've talked to, or one was a pulmonologist, another was a urologist. So, I mean, we have to get better. We have to get the word out there, and I think it's
We
great.
do.
Hopefully, this podcast will help.
Great. Well, I certainly am. It's an eye opener for me to see how effective TERS is, and for me to be able to speak to you, Ron, who invented this technique or discovered this technique 15 years ago now. There's increasing traction. There's more interest in it,
Right.
but I think that there's a lot of healthcare professionals who are specialists in veins and they don't know about it. So I'm going to show this podcast, going to show your technique. We'll do a literature review of the small amount of literature there is.
Right.
And hopefully there'll be more interest in it. The thing
Yeah.
I also wanted to talk to you about was the emerging field of dermatophlebology. You've also kindly sent me a presentation about that, which I'm going to show now, and then I'm going to come back to you for some comments. And then I also want to ask you about your new educational resource where you ask for a small donation and lifetime access to all the educational material that you produce. But let's look at the new field of dermatophlebology and then come back to you for some comments. And then you can tell me about your new your new website, which provides education.
Okay, today we're going to talk about dermatophlebology, what it really means. And this is a term that I coined at a conference about a year ago that explains the pathophysiology of the venous circuit in the dermis when you have cutaneous venous hypertension. Now, cutaneous venous hypertension, all that means is that there is high pressure from the venous system that's transmitted into the dermis through the ascending branch from the reticular vein that's subdermal. And you can look at the diagram here. It kind of explains what we're talking about. So it's numbered and it's pretty self-explanatory. So the ascending branch is always the gateway for pressure transmission. All these little vessels in the dermis have valves. If one valve's bad, then you're going to get pathology someplace. Now, changes may occur in the squamous epithelium, such as spongiosis, which we'll talk about later, the papillary or reticular dermis. By understanding the various responses to cutaneous venous hypertension, it's easier to diagnose and treat the cutaneous manifestations of venous disease. All SEEP classes contain some manifestations of cutaneous pathology. I think I want to make it quite clear that if you don't have changes in your dermis, you don't have symptomatic venous disease. There is a polygonal drainage system that we're showing you here. It's very characteristic. This is from the work of Manishi. The pattern of venous drainage is not set in a straight line. It's actually may or may not communicate. And most of these polygonal drainage systems in the lower leg are triangular in shape. Probably seen this in your patients, especially in the lateral reticular system. Now, dermal changes that occur. Edema. So edema is very characteristic in the dermis, and it can occur with an underlying varicosity. It can also occur around the spider vein. So edema is the first evidence we have of increased pressure that's transmitted through the venous circulation. Now, of course, we also have hypertrophy of the vessel wall if there are spider veins that are present as well. So C4 categories based on 4A is called pigmentation and venous eczema. Well, this is really pretty inaccurate. Bronchiolic edema is present in all patients with venous eczema, may or may not be with stasis dermatitis. So pigmentation is not really related to C class 4, except when you have stasis. When you have venous eczema, you have spongiolitic edema with very little dermal involvement. The discoloration of the skin is actually from the squamous epithelium and usually from pruritus. So if you have a lot of itching, a lot of pruritic symptoms, you get chronic skin changes. But that's not from pigmentation such as the hemosiderin deposition. So this is edema. This is venous eczema with some edema. You don't see it here with stasis dermatitis. So it's quite different, yet they're grouped in 4A category, which is really inaccurate and needs to be changed. So telangiectasia, according to the study of dermatophlebology, dermatophlebology have distinct classes. Okay. Now there are classes of telangiectasia that are associated with cutaneous venous hypertension. The red telangiectasia are about 150 microns in the subpapillary plexus, which is continuous. Now the blue ones are about 500 to 600 microns in depth. There may or may not be continuity with other polygonal drainage systems. So there's distinct categories of telangiectasia associated with cutaneous venous hypertension. The red ones you see are in the subpapillary plexus. The blue ones are in the dermal plexus. You may have both together or you may have either one alone. Depends on where the valve is damaged and the method of pressure transmission. So angiogenesis. Now this is commonly found in reticular dermis. It's the same level that the blue telangiectasia occur. It's not associated with venous hypertension, but rather with inflammation. You can see here the wall of the vessel is thin. There are lymphocytes present. You never see lymphocytes unless you have inflammation. Now we do see inflammatory changes with lymphocytes in some vessels overlying varicosities. So what we do is a lot of times we'll do the punch biopsy. We use a 1 millimeter punch to do the phlebectomy, and we'll examine the skin overlying the varicosity, and we find edema in the dermis itself. This may explain why some people have more symptoms than others, such as itching, pain, etc., because they have more inflammatory changes. So this is generalized essential telangiectasia. The vessel wall is hyalinized, does not respond to sclerotherapy. If you do sclerotherapy, you're wasting your time. This has to be treated with a low wavelength laser or IPL. So in conclusion, this is a very brief overview of dermatophlebology. We have a lot more that we can discuss, but I wanted to tell you what we're actually investigating now. We're looking at the venous changes that occur in the dermis, which really have never been studied very well. So this dermatophlebology is simply the study of the alteration of the venous circuit in the 2 millimeter thickness of the skin of the lower leg. Transmitted high pressure causes a multitude of findings. By studying the different modalities of treatment, we can actually study and know how to plan our effective treatment. So any other information that we can help you with, just contact us by email. It's very, I think, a new developing specialty. Or just kind of a brief overview of the dermatophlebology. I'm also going to attach a paper that we recently published. And also there's a textbook coming out in the next few months.
This is something that a lot of vein specialists don't know. And I think it's because you have routinely performed phlebectomy through punch holes, through punch biopsy, and you've sent those biopsies away for analysis. And that's led to your interest and knowledge about dermatophlebology. Tell us a bit about that.
Well, I think that my interest in dermatophlebology really started when I moved to Florida, and Peggy and I were just going to maybe open a small clinic and do some sclerotherapy, do some things in the office. But then Ted Schiff contacted me. Ted Schiff was the founder and is the president of all the Water's Edge dermatologies, now called Aqua. There's about 130 clinics. Ted and Dr. Shama, Nick Shama, were classmates. And Nick Shama and I did a lot of the early work on histology of what happened after you do a laser. What does the vein look like? And histology of the venous aneurysms. Excuse me. Ted said, "Why don't you come here and work?" And I said, "Oh, good idea." So I started doing veins in a dermatology practice, and then I had access to the dermal pathology lab. I have my own Cytotech technologies. He works just for me when I do my specimens, but he works for the lab. But he's the only one that does my specimens, and he's superb. I mean, he gets everything you see from our work is, for the most part, through 1 millimeter punch biopsies. As you mentioned before, I use that many times for doing phlebectomies. How I got started doing with the spider veins is that we would, as you mentioned before, this technique of doing tumescent and then doing the sclerotherapy afterwards. Well, as you see, when the spider veins fan out, the point from where they fan out is a point of their dermal perforator entrance into that complex. And each group associated one dermal perforator. So we started doing like foam sclerotherapy or using different solutions to see which would give us the best result of sclerotherapy. and we would do a punch biopsy of the dermal perforator. Everybody got a punch biopsy of the dermal perforator. And then as we gained more knowledge, we also did punch biopsies of the larger intradermal varices. So we could actually see what these look like, what they look like after they were treated. And so that kind of got it really interested in what was going on. And so when I read Manishi's report on polygonal drainage, everything kind of fell into place about, gee, this is what all this stuff's about. So we were able to reconstruct, and I'll tell you in a minute how we did that. But for the most part, we're doing, let's say, class 1, SEEP1 SEEP1 category, spider veins. It's common knowledge that spider veins are theoretically cosmetic. But what dermatophlebology has taught us when we do our biopsies is that maybe that's not always so, because we can see in the specimens many spider veins have associated reticular edema. So that's a class 1 with edema. Does that make it a class 3? So what I'm getting at, the SEEP categories are all wrong. Study of the dermis has proven that it's much more complex than just 1, 2, 3, 4, 5, 6. Spider veins can also be aneurysmal. Okay, what's an aneurysmal dilatation of the spider vein? Well, it's 3 times the size wall thickness of a normal spider vein. So all spider veins have thick walls. Okay, now other thing in dermatophlebology that you can see is that, wait a minute, not all spider veins do have thick walls. There are some that have thin walls, called generalized essential telangiectasia. They do not respond to sclerotherapy. But we know from our studies, after we've actually done specimen biopsies to confirm it's GET, we have a patient that we've treated, not clearing up. I suspect it's GET. I will do a biopsy. The reason is that I can tell the patient, look, you're not going to clear up with sclerotherapy. You may clear up with IPL. You may clear up with laser in a certain wavelength, okay? Usually a V-beam, which is about 590. But you're not going to clear up with sclerotherapy. It's just not worth doing it. And so they have to, that you tell them that so they can at least know that they have the option of going on having further therapy. It's going to be more expensive for them, probably. So red spider veins, everybody goes, well, we have red and we blue. Why do we have red and blue spider veins? Okay. Well, we have red spider veins because they're in the subpapillary plexus. That's where they reside 100% of the time, 150 microns below the skin level. Why do we have, and they have less, desaturated blood. Why do we have blue spider veins? Well, they're in the mid-dermal, classified mid-dermal area, but they're really not mid-dermal. So the dermatophlebologist and I did about probably 30, we took 30 slides of a lot of the spider veins we've done, and we measured the actual depth of a spider vein, the blue spider veins. Most of them are at 500 microns, 500 to 600 microns below the skin sector, consistently. Very surprising, but that's the case. That's where they are. Now you can have deeper ones. Here's the trick. You're not going to see them. You only see the ones that are in the upper dermis. You very rarely ever see the ones in the lower dermis, unless they're really dilated. Now, when you have aneurysmal dilatation, you have many spider veins that are dilated per microscopic field. Whereas when you have an aneurysm, when you have a regular spider vein, it's one. So, these are the things that we've come across in dermatophlebology that we've learned about and correlated with the ultrasound findings. That's in SEEP1 alone. Now, SEEP2 category, okay, we're looking at that now, and that's been reported that some patients with disc varicoses will have dermal edema. Okay, that's been reported by, I think, Kalagi did that and had a paper on that. And that's true. We see that one time. And probably about 20-25% of the patients will have dermal edema, which when you scan the varicose, you can see a really thick dermis above it. Now, if you've ever really thought about this, why aren't there spider veins above the varicose? Very rarely ever see that in another location. So is a dermal edema secondary to venous hypertension, okay? Or is it secondary to lymphatic obstruction? in these patients. And that's what we're trying to determine now. It's really difficult to see lymphatic channels. We don't have electron microscopy. We just have the standard examination, microscopic examination. So that's what I'm looking at now, categorizing how many patients with actual, just what we would consider CEAP2, have actual edema. And why that's important was that puts them in a different category, right? They're no longer class 2. That ups the venous severity score by 3 right there. Just having edema. Because that edema doesn't go away. Okay, it stays there. Now, is it lymphatic or venous? I think it's lymphatic because when we do the biopsies, I've seen some channels, but we don't see thickened blood vessels. We don't see increased blood vessels in the papillary dermis. So by just inference, I think it's probably lymphatic, isolated lymphatic drainage disturbance just around the varicosity. Then we have class 3, which is a standard edema. Okay, well, now we've seen there's edema in class 1, there's edema in class 2. So, I mean, we have to be more specific, saying this is edema in the subdermal tissue. Okay, because class 3 really means in the subdermal tissue, because most people with edema don't have edema in the dermis just from venous insufficiency, unless they have other pathology, which leads us now to CEAP4. So CEAP4, by the revised standards, CEAP4A is described as eczema, okay, and pigmentation. It's grossly inaccurate. Eczema has nothing to do with pigmentation, okay? When you see pigmentation, eczema, that's just from skin excoriation, okay? If you do an eczema biopsy, okay, a biopsy of a patient with eczema, what you see is a different type of edema. A true eczema venous patient will have what's called spongiosis. They'll have actually edema in the squamous epithelium, which you don't see unless you have eczema. And eczema, that's a classic finding, any kind of eczema. Eczema from allergic reactions, from poison ivy, whatever. They all have spongiosis in the squamous epithelium. And we've actually seen patients with eczema have spongiosis in the squamous epithelium. Have these they're actually like little cysts of water, little cavities of water in between the keratinocytes. I mean, it's a very interesting finding. How that occurs, not really sure. It's some immune regulated response, but pigmentation, they don't have pigmentation in the tissue, in the reticular dermis, okay? You do have pigmentation with stasis dermatitis, but you shouldn't class that as the same category as eczema. They're different. So maybe there should be a class 4A that says only eczema. Class 4B should then maybe be reserved for stasis dermatitis, which is pigmentation, secondary to red cell extravasation and hemosiderin deposition. So I think dermatophlebology is just evolving, and we'll learn more and more. And I think another important part, if you don't have skin findings, you don't have symptomatic venous disease, period. And so even people with spider veins may have symptomatic venous disease, especially if they're aneurysmal. And if they're aneurysmal, especially down by the foot, they bleed. They're a great source for bleeding. If they have edema, I think these patients, I've seen these patients have more problems with pruritus and kind of skin sensation changes. And that may be the patients who develop that, the ones that have the edema. So that's kind of how we got into that. And we're still studying this and trying to go and to learn more. And like I said, now we're trying to find out how many patients actually develop dermal edema varicosities. Because I think it's important, because the insurance companies get more and more regulated on who they're going to treat. Well, now you have somebody with dermal edema with varicosities. It's not just simple varicosities, it's something else. Do they have more symptoms? That's what we're trying to see. Do they have more symptoms of heaviness and fatigue? It's a possibility. So we're just still in the early phases of this.
Well, it's great to hear, and great to hear how you're taking this forward, Ron. I'm going to wrap up now by signposting people to your website where they can find out more about Dermatophlebology and the resources. I'm going to put a link in the description box below, but very briefly tell us what people might get from becoming a member of that website. All the educational resources they'll get.
So this is my goal in my later years of doing venous treatment, is to actually put on videos, okay, and courses what I've learned from my years of experience. And it goes for a good cause. It helps support an orphanage over in Nepal. And if we get more and more, we'll support more, you know, support more charitable causes. We have a lot that we could support. So it's not, it's, I think it goes for a good cause. It also, if you read a journal, okay, and my last journal article, hopefully I published, was last year. But I don't like publishing journal articles. I'll tell you why. Because a journal charges a doctor to read what I wrote, right? And so, the only reason for, you say you want to expand medical knowledge by printing in a journal, well, you're fairly limited on how you can actually spread knowledge. Now, with our courses, which you actually see, and Peggy puts them together. She's great at editing all these courses. And I think, and we're sending you the courses too, all of them. You can see that they go from doing videos to didactic to videos. You can actually see the procedures. You can't see this in a journal article. You can't see how I actually do something, okay, how I actually do a lobectomy, or how I actually do these techniques of doing tumescent and injections, and how we treat the spider aneurysms. I looked up before I came on here under Google search, spider aneurysm dilatation, telecentation. There's nothing, even though that I presented it sometimes at courses, and they actually mentioned it in our Dermatophlebology article, but there's nothing actually written about it. And they're a whole new animal from as far as treating compared to regular spider veins. And so I think this article the courses that we do show you how we do it. We use a tumescent and a punch. We do really a lot of mechanical debriding for these big ulcers, and you get a great result. It's really phenomenal what a great result you get.
I watched a video that you made, or you and Peggy made, at a presentation. I can't remember which one it was. It might have been in the UIP meeting in Pisa in Italy, about tumescent assisted sclerotherapy for reticular veins and spider veins, and I adopted that, and it was because of the video presentation. Ron, you're a legend. I think your website is a great educational resource.
Right.
I'm going to put a link in, and I hope that people that watch this video will be persuaded to become a member and to, in that way, support a great charitable cause that you and Peggy are very interested in. I think we should, with the TERS technique, we should be able to help more people with leg ulcers. And I think your video presentation is excellent. Thank you very much, Ron.
I'd like to add one thing, if I could.
Yeah. How
this charitable cause for this particular orphanage came about. We were in Nepal, going to hike in the Himalaya mountains, and we were in Kathmandu, and some Buddhist monk, okay, retired Buddhist monk, came up and said, "Hi, would you like to help the children?" I said, "Well." So the guy takes us to an orphanage that the people had nothing. And then, of course, Peggy just fell in love with these kids, and from then on, they've been like our children. So there's other causes. There's so many causes that we can help, and other people can help. So you learn something, and you learn a lot of knowledge, and you're going to be helping people. That's why we do the courses.
Fantastic.
Yeah.
You and Peggy are an inspiration, Ron.
Right. Well, thank you. It's been great talking to you.
It's been a delight and a pleasure, and thank you so much for joining me from Florida. Thank you very much, Ron. All right. Take care. Bye-bye.
Bye.